Hi, this is your discussion on seizures and other seizure disorders. So, when I talk about seizures, we are talking about an abnormal electrical firing of the impulses in the brain. What you are seeing on this slide are impulses or recording of the electrical firing of the neurons. So you have different waves here. Here, you have your gamma, you have your beta, alpha, theta, and delta. Okay, these are not for you to memorize, but just for you to familiarize. Okay, that these are the waves that could be seen in an EEG tracing. Now, here is the comparison of an EEG tracing along with your ECG tracing. So as you can recall, class, your ECG is used to evaluate for your cardiac functioning, whereas your EEG is used to evaluate for your brain functioning. Okay, so for us to say that somebody is brain dead, we need an EEG flatline. But oftentimes in the clinical setting, what we are using is the determination of clinical death, okay, is your ECG. Okay, but just for you to have a comparison, okay, as you can see, it's very different. Okay, your EEG tracing is very different compared to that of an ECG. Now, seizure. When I say seizure, it is resulting from sudden excessive discharge from cerebral neurons. Your keywords here are sudden excessive discharge. Okay, and this is characterized by episodes of abnormal motor, sensory, autonomic, and even psychic activity. So take note, class, it is coupled by motor, sensory, autonomic, and psychic activity. Now, epilepsy. Oftentimes, we're hearing the term epilepsy, okay, interchangeably with seizure. But when I talk about epilepsy, class, your epilepsy is characterized by at least two unprovoked seizures occurring more than 24 hours apart. In other words, there is no trigger, okay, that could be easily identified, unlike your seizure, which could be triggered by febrile episodes. Okay, for epilepsy class, you will just notice somebody seizing, okay, at least two of which occurring more than 24 hours apart. So that's how we can say that somebody is a person with epilepsy. By the way, just as a point of reference, we are not anymore using the term epileptics. Instead, we are saying CWE, children with epilepsy, and PWE, people or person with epilepsy. Okay, your epileptic is considered to be a not a socially acceptable terminology and not a politically correct terminology. Now, there are several types of seizures, okay, that would depend on their characteristic, but for this one, this depends on cause. Now, the type of seizure, according to cause, is considered to be primary if it is idiopathic or genetic, meaning there is no identifiable cause other than the genes of the patient. Then it considered secondary if it is organic or acquired, okay? Organic in the sense that there is an underlying pathology that has led to seizure. It is considered acquired if it is secondary also to disorders or disease processes. For example, if I'm talking about a patient with stroke, okay, hemorrhagic stroke, and then the patient would have seizure, that is considered to be a secondary type of seizure. But when I'm talking about a pediatric child who is having seizure, even without fever or without underlying infection, okay, the child may be having a primary seizure episode. Now, there are several phases in your seizure activity. One is your prodromal phase. Okay, class, in your prodromal phase, other references would refer to this as your pre-ictal phase. It is where the prodromes and the aura would be present. Just like your migraine, if your migraine would have warning signs, your seizure could also have your premonitory signs. Okay, some class would complain of double vision. Okay, common among patients with epilepsy is your epigastric pain or discomfort also. Okay, so class, the presence of this aura would warrant or signal the occurrence of a possible seizure. So oftentimes our patients are able to identify this aura because of the prolonged or chronic, okay, involvement with the disease process already. Okay, that's your prodromal phase. So class, just as an update, okay, you might have noticed that in the past, tongue depressors are used to manage patients who have seizure episode. Okay, so the usual intervention done by the nurse is that to prevent injury to the tongue, okay, to prevent injury to the tongue, what we are doing is uh, they're having the tongue depressor. Okay. However, the use of tongue depressor is already considered obsolete as of this time, because according to studies, the use of your tongue depressor would only lead to more risk for injury. Okay, rather than helping the patient, it leads to more risk for injury. So for that reason, class, the use of your tongue depressor is not anymore recommended in seizure management, unless, okay, unless that the doctor ordered for it. For example, the best time that you will be using the tongue depressor class is during the aura episode. Okay, why the aura? In such a case that if the patient class will have seizure episode, okay, you will not have hard time to open the jaw of your patient and to prevent the tongue from being bitten. Okay, because if you picture out somebody with seizure, you could not even move them. Okay, you could not open their jaw, okay? You could not open their eyes because they seem to be too stiff. Okay, now that's just a reminder that the use of tongue depressor is usually incorporated in the aura phase or the prodromal phase, unless class it is contraindicated by the physician. Second, ictal phase. During the ictal phase class, that is the area or the time wherein seizure activity is very active. Now, you need to note class that your responsibilities as a nurse during the ictal phase is to ensure still the patency of the airway. Okay, so by ensuring the patency of the airway, what would you do next? Okay, class, you need to observe the patient and you need to provide safety for the patient. Okay, class, when I talk about safety, we're talking about padded side rails. We're talking about pillows under the bed or under the head, I mean, of the patient. We're also talking about the bed on the lowest position so that the patient's fall, if ever he will not be detrimental on the part of the patient. Then class, also it's important for the nurse to note the duration and characteristics of the seizure. This will help us monitor if there is any progression of the disease process, especially if this is of organic cause. Okay, but if we're talking about seizure who have genetic implications class and seizures who have been hereditary, okay, the tendency of your patient is to have the same signs and symptoms every time they would have a seizure episode. Okay, then you have your post-ictal phase. In your post-ictal phase, there is confusion and behavior changes. Plus, during the post-ictal phase, your patient will be confused what happened. Okay, oftentimes we answer them that you had an attack. Okay, and then you are trying to assess their level of consciousness. Okay, by asking questions about orientation. Okay, now some of the patients may also have behavioral changes. That's why you need to be very understanding to this patient. And during the post-ictal phase class, you need to anticipate that your patient may be sleeping also. Okay, why? The body has been exposed to too much stress because of the hyperexcitability of your neural tissues. Because of that, the body is in stress. The body is tired. That's why sleep is recommended for these patients. Okay, added to that, okay, your seizure activity would usually affect all ages. And the common causes are your febrile states, metabolic, and then you also have your toxins. Okay, class, too much toxin in the body could cause seizure. Lack of oxygen in the body could cause seizure. Overdosage of a certain medication could cause seizure. Okay, so you need to remember that it comes in all ages. Next, you have what you refer to as your epileptogenic focus. Class, when I say epileptogenic focus, that is where, okay, your epileptogens, okay, that is where your epilepsy is coming from. Okay, so we have unstable neurons that would initiate seizure activity. And then class, you will become hypertensive and hyperactive, which can recruit to adjacent neurons. Okay, again, your unstable neurons, which can initiate seizure activity, could recruit the adjacent neurons. Okay, and then class, they would trigger for the firing of these neurons. So take note that your epilepsy or your seizure episode are a cascade of series of neurotransmitters. Okay, so there are a lot of neurotransmitters working out for the seizure to ensue. Now, unstable neurons that initiate seizure activity would become hypersensitive and hyperactive, and this can help recruiting adjacent neurons. So when he recruits, or when these neurons would recruit others class, the tendency is that there will be an involuntary firing of electrical impulses. Okay? Now, we have the term seizure threshold. Class, when I say seizure threshold, this refers, no, okay, this refers to all people, okay, wherein they have the threshold, wherein the cell membrane can still stabilize and control the electrical discharges of the brain. Okay? So, class, your seizure threshold is the limit of an average adult as to how long he can sustain as long as to prevent a seizure episode. So, class, your seizure threshold is a reminder that all people are at risk of seizure, but others would have a higher seizure threshold compared to others. Okay, so class, that would help us determine, or that would help us identify the people at risk for seizure. Now, your common origin of seizure will be your gray matter. Again, the seizures originate from gray matter and not from your white matter. Now, class, for the pathophysiology. Normally, class, an active mind would have the electrical activity unsynchronized, whereas a mind at rest would have the electrical activity to be mildly synchronized. Now, what happens is that when the triggers, class, are there, once there are the triggering mechanism, let's say, for example, fever, infection, stress, okay, once these mechanisms are triggered, class, sudden abnormal burst of electrical activity will be happening. Okay, and that burst of activity, class, could either result to generalized seizure or partial seizure. How do I differentiate a partial seizure from a generalized one? Class, your partial seizure would only have localized signs and symptoms, whereas your generalized seizure would have widespread distribution. Okay, so the term generalized meaning it's general, the effect would be general. Now, let's talk about the classifications of your seizure. Okay, you might be looking at GIF right now that may look unrealistic, class, but could actually happen also to an actual patient with a seizure episode. Now, the first classification is your partial seizure. It is the most common form occurring in patients with epilepsy. Okay, this only involves one area of the cerebral cortex and the manifestation would vary on that area affected. Now, class, your partial seizure may be of simple, focal, or Jacksonian type. Okay, and the manifestations are listed there. So, class, when I say simple motor seizure, uh, it's simple. Okay, it involves one motor, one abnormal motor movement. When I talk about the focal motor seizure, one area of the brain is affected. When I talk about Jacksonian seizure, it is electrical activity that is not only spreading, okay, to the site of nerves, but would spread to adjacent parts. Now, what are the manifestations of your partial seizure? Okay, there will be stiffening or jerking of a limb or one side of the face. Okay, look at that, stiffening or jerking of a limb. So, class, when the limb, okay, would suddenly harden up, okay, or would suddenly kick you up, okay, without any reason, that may be a seizure episode. Then, head turning or head deviations, butterflies in the stomach, which would feel as sensory signs, and then you have your respiratory and cardiac changes. Okay, so class, this may be the manifestation of your partial seizure. If you can notice, it would only involve one organ. Okay, let's say, for example, if we're talking about limb, it's talking about limb. Then we're talking about face, it's just talking about one side of the face. Okay, that's your characteristic for your partial seizures. Now, okay, so your partial sensory seizures, class, are transient sensory manifestations. Okay, these manifestations could involve numbness and tingling on any area, especially if we're talking about parietal lobe involvement. Here, bright lights, flashing lights, if we're talking about occipital lobe involvement, difficulty of speaking or total speech arrest if we're talking about the posterior temporal segment. Okay, so class, look at that. Recall that the function of your parietal is most on sensation. So class, you can recall here that the signs and symptoms, if it is a parietal originating seizure, would be your numbness and tingling on any areas. Whereas, if the lesions would end at the occipital portion of the brain, okay, it would manifest with lights. Okay, lights as in vision related. And then class, your temporal lobe is also in charge of speaking. Now, your complex partial seizures or your psychomotor seizures are characterized by an anterior temporal lobe, okay, involvement, which would begin with the aura. Now, this would affect your behavior, emotional, affective, and cognitive function, and may also possibly result to alteration of consciousness. Now, uh, your complex partial seizure may manifest as automatisms. When I say automatisms, these are non-purposeful and repetitive behavior that accompany your focal impairment awareness seizure. Okay? So this is your automatism. Again, non-purposeful, repetitive behavior wherein, okay, it would commonly accompany focal impaired awareness seizure. Then you have your outbursts of rage, class, or violence, okay, which could be a sign of your seizure. Then you have your amnesia. Now you also have the appearance. They may be wild-eyed. Okay, they may be speaking in jumbles and repetitive phrases. And there is clouding of consciousness or a confused state without any motor or sensory component. Okay, so take note, clouding of consciousness or confusion may be present. Okay, so without motor or sensory impairment. Now, look at this, class. These are the possible signs of your seizures, okay, depending on the body site which is affected. So you can see, class, okay, that bad or unusual smell is more likely if your patient would have, okay, a problem with, okay, your this part of the lobe, okay, this part here. Okay, your parietal lobe, for example, would lead to, I think it's referring already to part of your temporal lobe. Okay, so it would form auditory hallucinations, hearing music, okay, things like that. Okay, then we also have class, notice here the difference, or notice here the terms deja vu and jamais vu. Okay, class, your deja vu is the feeling that you've already experienced something, okay, even when you know you never had. Okay, so it's just like, oh, is this a deja vu? I have been recalling that this event, I think I have experienced this in the past. On the other hand, your jamais vu class is a phenomenon which is said to be the opposite of the deja vu. Okay, so here you are finding subjectively unfamiliar something that we know to be familiar. Usually your jamais vu is associated with neuropsychotic conditions. Now, you have your generalized seizure. Okay, previously we are talking about partial seizures. Now let's talk about your generalized seizure. When I say class generalized seizure, that would involve involvement of both of your veins, okay, or both part of your brains. So both hemisphere and the deeper brain structure, that would be your thalamus, basal ganglia, and upper brain stem may be affected. The big word here for your generalized seizure is negative consciousness. Okay, meaning the patient is not conscious when it happened and may persist to be unconscious until the time he is brought to ER. Okay, now onset is immediate. Take note of that. In generalized seizure, onset is immediate. Okay, then okay, there are several forms for your generalized seizure. Okay, one is your grand mal seizure, which is also known as your generalized tonic-clonic seizure. Okay, so here are the what happens on a grand mal seizure. So suddenly a patient would have sudden level of consciousness, and then after that the tonic phase would occur, followed by your clonic phase. Okay, that's why it's referred to as tonic-clonic seizure. Now, class, when I say tonic phase, what you can notice from this patient is that there will be incontinence, there will be cyanosis, and there will be generalized stiffening of the body and limbs. Okay, and the back I mean is arc. Okay, class, the arcing of the back is one of the signs that we refer to as opistotonus. Okay, so class, what happens in the tonic phase? Again, there is stiffening of the body and the limbs. So class, in the clonic phase, what happened is that there is jerking of the limbs. Okay, jerking class meaning the limbs are moving involuntarily as if it is shaking. Okay, as if it is shaking. Now, you notice also class in the clonic phase that the patient will still have persistence of cyanosis. The eyes blinking class could be present, and then salivary frotting needs to be assessed for. Okay, because class, if there is presence of salivary frotting class, I think we need, okay, a neuro assessment to verify, okay, to verify if what is the possible cause of this frotting, or if is this not a CSF which is possibly leaking. Okay, then class, you have your post-ictal confusional fatigue. Okay, so class, the tendency of your limbs will be well rested, and then the tendency class of the patient is to sleep for long hours after the seizure. Okay, their body would want to augment their energy that was lost during the seizure episode. Now, so class, what happens in your tonic phase? Again, the muscle becomes stiff, okay, resulting to what we refer to as your epileptic cry. So don't think, class, that the baby who is shaking is just having the epileptic cries. That's not how it works. Okay, then you have your opistotonic position. So class, recall opistotonus. Okay, there is backward, okay, backward curvature of your spine. Okay, that is your opistotonus. Okay, now arms and legs are extended and the jaw is clenched. This is what we have been referring to, class, that when you're using the tongue depressor, okay, you are not supposed already to uh, have your tongue depressor placed while the patient is seizing, okay, because that studies has found out that this will just result to injury. Okay, studies would find out that forceful entry of your tongue depressor would proceed to, uh, again, injury. Now, class, in the tonic phase of your seizure, the patient would appear to have urinary and bowel incontinence. In other words, okay, once the seizure is occurring, they would just urinate or would have their bowel moved there. Okay, there will be breathing cessation, class. That's why you cannot count, okay, usually for the respiratory rate of a patient with a generalized seizure. Okay, cyanosis would develop. For this reason, class, we deem oxygen as an emergency management for a patient with seizure. Then you have your pupils fixed and dilated. So recall earlier that once the pupils are fixed and dilated, it would mean that the prognosis of the patient is poor. But class, in this case, in your tonic phase class, the fixing and the dilation of your pupils class is indicative actually of an occurring neurodamage. Okay, in this case, that is your seizure. Okay, then class, your tonic phase would usually be running from 15 seconds to a minute, unless that your patient is having status epilepticus. Then you have your clonic phase. So class, in clonic phase, there is alternating contraction and relaxation of the muscles. Okay, the patient would have the manifestation of hyperventilation, and then the eyes would roll blank. Okay, roll back, I mean. Client would froth in the mouth class. Okay, the frothing is usually related to the saliva. It would vary in duration and subside gradually. Okay, the entire phase class would last not more than 60 to 90 seconds. Okay, 60 to 90 seconds. But if it is continuous class K, you might need to give additional medications to your patient. Then, let's talk about your minor motor seizures. So, class, we've discussed the types earlier. So, one is partial, the next is generalized. And then now we are talking about your minor motor seizures. Class, your minor motor seizures may be difficult to treat. No? This includes examples such as your myoclonic. So, class, myo. Okay, when I say myo, this talks about muscles. Class, your myoclonic seizures are shock-like jerks of a muscle or a group of muscle. Your atonic seizures, class, on the other hand, are sudden loss of muscle strength. Then class, you have your akinetic seizures, okay, which would involve drop attacks or dropped seizure. Okay, there is a dropped attack or dropped seizures. Meaning class, now, the suddenly a certain part of the body or an organ would just, no, or limb, I mean, would drop and then stop. Okay, so class, there are books that would classify akinetic seizure under your atonic seizures also. Okay, because your atonic seizure class would be characterized by sudden loss of muscle strength. Okay, whereas your myoclonic is a jerking of a muscle or group of muscles. Now, you have the term status epilepticus. Okay, class, status epilepticus is an emergency. Okay, it's just like me talking about your status asthmaticus, if you can recall the respiratory problems. Now, class, status epilepticus. Okay, your status epilepticus class is a rapid succession of epileptic spasms without intervals of consciousness. Okay, this could be a complication that can occur with any type of your seizure. And class, the result would be your brain damage. Okay, so again, it is a rapid succession of epileptic spasms without intervals of consciousness. What do I mean by that? For example, okay, if it's right now, it's 8 a.m. Then the patient had a seizure, and then the seizure ended by, let's say, for example, 8:05. Okay, the patient was asleep. Okay, or the patient is asleep after the seizure episode. Class, by 8:20, for example, okay, the other child could still, if the child had another seizure episode, we might suspect already that there is epilepsy. Okay, so class, the problem there is way going back to brain damage. That's why to reduce brain damage, hyperoxygenate the patient, start oxygen to your patient, and try to halt the seizure to decrease the oxygen demand of your patient. So what is our priority for a patient with status epilepticus? Class, you would want to halt the seizure because if it will continue, brain damage, brain dead. Okay, but first priority is still your airway. Okay, so you might need to position the patient on the side, class, because of the secretions from the mouth. And then class, you would also need the patient care. You need to provide other than oxygen. You might need to provide suction machine at the bedside. Okay, because class, if your patient will be having seizure, they are not able to drain their suction. Okay, or they are not able to drain their secretions. Hence the need for suction. Then we also use the administration of your anticonvulsants. So class, your anticonvulsants are also known as AEDs. So when I say AEDs, these are anti-epileptic drugs. Okay, so class, you have a lot of anticonvulsants. One example is your levetiracetam. Another example would be your I'm thinking of another example. Anticonvulsant, you have your phenytoin. Okay, then you have your sedative class. For your sedative, you have the family of diazepam and midazolam for sedative. Then class, you have your supportive care, especially if we're talking about parenteral nutrition here. Okay, if we're talking about the blood sugar, glucose monitoring. Okay, things like that for your patient. And then continuous monitoring. Status epilepticus are usually admitted in the ICU, okay, for close monitoring. Next, you also have your laboratory and diagnostic test. Okay, so class, a neuro exam needs to be comprehensive. Okay, when I talk about the neuro exam, you're examining the 12 cranial nerves. Okay, you're examining all the findings that is common in our setting. Okay, then you have your EEG. Again, your EEG will be able to identify your brain waves. Okay, brain waves. Now, skull X-ray is used, class, to rule out for the presence of edema or possibly your fracture. Okay, so you have your CT scan, the same purpose. Then you have your lumbar puncture. So the purpose of your lumbar puncture is to rule out for meningitis. Recall that meningitis is one of the common causes. Okay, your meningitis is one of the most common causes for infection in the neurosystem. Then you have your blood studies. Okay, your CBC, of course, as baseline. Your electrolytes, which would watch out for sodium imbalances that could manifest as seizure. Okay, then you have your blood urea, which could be waste product going towards your brain. Okay, now, if that will be going towards your brain, cannot be excreted by your body, class. Okay, that would also be toxic. Okay, and that could trigger a cascade of abnormal neural activity. Then CBG, hypoglycemia could lead to seizure. Hyperglycemia, class, if we're talking about DKA, okay, you might be wondering, okay, or thinking, okay, of a patient also with the possibility of seizure. Then you have your VDRL or RPR. Recall that your VDRL or RPR are diagnostic tests of choice for, okay, syphilis. Okay, so why are we talking here about syphilis? Class, your syphilis, if it would not be resolved, okay, could result also to cranial damage. Okay, so in that case, class, you have your neurologic syphilis also. Now, pharmacology. So I mentioned about anticonvulsants. So you have your phenytoin, dilantin. And then class, I would raise again the question, why would the doctor order, okay, diazepam 2 milligrams now, and then at the same time he would order phenobarbital 300 milligrams to run after 30 minutes, okay, or to administer after 30 minutes? Why would the doctor have the administration of benzodiazepine and barbiturates? I hope you already know the reason. By the way, class, just as a reminder, when we're talking about phenytoin dilantin, the prominent finding or side effect of your dilantin, class, is your gingival hyperplasia. In other words, the enlargement of your gums. Now, collaborative management. Yes, there is a resective surgery. Okay, class, this is the most common epilepsy surgery that would involve the removal of a small portion of the brain. Okay, that small portion of the brain would actually help to resect, okay, to resect the nerve impulses. Now, so the surgeon would cut out the brain tissues in the area of the brain where seizure would occur. So usually we are referring here to the site of the tumor, okay, or maybe where the injury occurred, or maybe where the malformation is present. Okay, now we have your ketogenic diet for seizure patients, or especially epileptic patients. Okay, literatures would say that doctors would recommend for ketogenic diet, especially if the patient's seizure is not controlled, class. Okay, is not controlled even after we had one AED. Now, when I talk about ketogenic diet, you need to note that, okay, this is a special high-fat, low-carbohydrate diet that would help control your seizure. Now think, okay, why are we having high-fat and low-carbohydrate? It seems that your body would want to use high carbohydrate, okay, or high fat, I mean, and then low carbohydrate. So what do you think will be the reason for that? Okay, so class, your ketogenic diet will be able to induce ketosis because of the use of fats or the high fat diet and then the low glucose diet. The body would not have any option but to use the fat which is being induced or but which is being ingested, okay, in order to provide energy for the body. And this would result to a condition referred to as ketosis. Now, class, when I say ketosis, that would involve, okay, the increase of ketone bodies in your bloodstream. You might be thinking of the condition diabetic ketoacidosis. Okay? Plus, if I would be able to differentiate between ketosis and ketoacidosis, your ketosis may be considered as normal levels of ketones in your body. Whereas, class, your ketoacidosis, your ketones along with your acids is already considered to be not healthy and detrimental already to the health of the patient. Okay, so that's how ketosis is differentiated from ketoacidosis. Your ketogenic diet would only result to ketosis. Okay, however, class, literatures are not yet very solid about the recommendation in your ketogenic diet. Next, during the seizure, what will be your activities? Okay, so class, privacy is one. Okay, to protect the patient from the onlookers, to ease the patient on the floor if the patient is on the side or standing somewhere else, protect the head with a pad, and then loosen constrictive clothing. Your priority is the safety of the patient. And then, if you are if the patient is in bed, class, okay, there's a foam there, you need to remove the pillows and raise the side rails for the safety of your patient. Now, also, class, if your patient is having an aura, which is on the prodromal, on the preictal phase, class, you need to insert the oral airway already. So, class, your oral airway may be in the form of your padded tongue depressor. Okay, so you have your padded tongue depressor. Then, do not attempt to pry open the jaw if clenched. And then the patient is not restrained during the seizure incident. Okay, so class, if you will be restraining your patient, you are just increasing the risk for injury. Okay, allow the patient, class, allow the body to do the jerky movement, allow the body to undergo the tonic and the clonic phase. Then, you need to place head on one side with the neck flex. Okay, this would allow for the drainage of saliva, class, preventing the risk for aspiration. Class, after the seizure, your patient would be placed on what we call the recovery position. Class, the recovery position will be the patient on side-lying position. We attempt to orient the patient. Class, one way for you to find out if it was an actual seizure or not, okay, especially tonic-clonic, class, is to ask your patient if they can recall what happened during the seizure. If your patient, class, is just malingering or faking out a seizure, they will be able to narrate to you the entire seizure incident. However, class, okay, if your patient had a generalized seizure and then, class, they are unable to recall the event, that's how an actual seizure would look like. Okay, they had loss of consciousness, so they would have no recall of the incident. They would usually describe the post-ictal phase as a very tiring phase, class, okay, wherein they would feel that they had a lot of activity. Then, make sure that the airway is open. And then, class, persuasion and gentle restraint may be done if the patient is agitated. Okay? If you are orienting also, class, the patient after the seizure, please don't give a lot of details to your patient because your patient, class, may be still confused, or your patient, class, may still be tired and then they would want to sleep. Okay? But you need to orient them on what happened. So, class, this is your recovery position. The patient is placed on side. Okay, that's to facilitate, class, the drainage of the secretions and then to allow for the relaxation also of your patient. Okay, so what are the nursing diagnoses for this patient? So, class, you have the risk for ineffective airway clearance, the risk for injury, anxiety is there, risk for aspiration is there, knowledge deficit, class, and then ineffective individual coping. Okay, class, these patients, especially if you're dealing with young adults, okay, will have ineffective individual coping because they think that they are unable to do their jobs. Now, if you are dealing, class, with patients with seizure and then persons with epilepsy, class, if you will be asked if they can still work on the job, yes, they can. Okay? Can they drive cars? Yes, they can. Okay? Can they perform activities of daily living? Yes, they can, provided that their seizure is controlled. And the control of your seizure would entail the need of your patient to be on maintenance medications. And when I say maintenance medications, class, this could not be discontinued within just matters of months or years. Okay? There are cases, for example, that for the lifetime they would have their seizure medications. Okay? But, class, if the control of your seizure is not yet gained or the seizure is poorly controlled, patient is not supposed to drive. Patient not supposed to operate dangerous machineries. Patient not supposed to cross the street alone. And patient is not allowed to swim alone. Class, especially if we're talking about seizure activity, okay, that is yet to be recurring. Okay, especially if the seizure is not controlled. Now, how many anti-epileptic medications may be needed by our patient? Class, there are instances wherein your patients may need combination of medications. The combination of medications, class, is necessary to gain seizure control. Okay, there are patients, for example, who would have a barbiturate and then combined with another class of medications. Okay, you have a lot of anti-seizure medications depending on the case of the seizure. Okay, you have your lamotrigine, for example, you have your phenobarbital, you still have your levetiracetam, okay, you have your phenytoin, and the vast classification of those anti-seizure medications. The education for your patient on anti-seizure medications is to ensure compliance, okay, and then class, to have the daily checkup, or no, to have the regular checkup with your doctors, okay. Then class, these medications could not be discontinued abruptly, okay, they need to be tapered down, or else, okay, your patient will be at risk for rebound seizure episode. Okay, you might be considering here status epilepticus to occur to your patient. Now, the next topic that we will be discussing is your craniocerebral trauma and head injuries. Ladies and gentlemen, thank you for your attention.